And good afternoon, Dr. Duke Majan. It is January 17, 2023. We're getting ready to start a Duke laser disc repair on a patient who actually happens to be a doctor himself. He's here with his wife, who's also a doctor, and they're traveling from Canada to Florida to have this procedure performed. Now, he has had a laminectomy in the past, which we won't talk about because it's caused so much damage and destruction. You can see it on the MRI. But the problem he's having now is herniated disc at L4-5 and L3-4. And those herniations are off to the side and they're strangulating the nerve roots in a process called spinal stenosis. How's he doing?
Doing great.
Huh?
Doing great.
All right, we're going to get started. Now, our patient is sedated. Our anesthesiologist has him sedated and comfortable. So let's see. He's going to have one of those deeper spines. Lay still, you're fine. All right, there we go. That looks good. I'm aiming for the L4-5. You guys can see the L4-5. Jordan, maybe you can show the audience.
We see it.
Great. So that's the first disc that we're going to go for. And as I approach the facet joints, I can feel them. I'm going to sneak just underneath them. Let's get an AP and see where we are. So the approach we use is called transforaminal. Trans means through or across, foraminal. All right, so too much in the midline. I need to be more lateral. I need to be further lateral. So we're too posterior. Now he has, unfortunately, one of those spines that's very deep. All right, I want to be a little more superior towards the head. Shot. Yep. Still a little more superior. There's the facets. Now we need to get around the facet joint. Shot. So the approach is called transforaminal, and it means to go through or across the neuroforamen. The neuroforamen is a hole that's already present in the spine. Is he reliable? You guys can see the L5-S1 disc there, Jordan. Show us the L5-S1. Yep, that's the bottom disc. We're not going for that one today. We're going for L4-5 and L3-4 above it. Yep, those are the two discs we're trying to treat. Now we're going to do an AP view. All right, that looks better. So our needle is more lateral, the tip, right at the foramen, right where the facet joints are. So the idea is to basically glance Arius off of the facet joints, just lateral to them. And if you do that just right, you'll be exactly where you need to be. Shot. You'll come in underneath the exiting nerve root and right into the bad disc. All right, you can see we're almost there. Just lay still, you're doing great. So, shot, one down. I'm bumping up against the end plate. I'm going to redirect a little bit. Yep, that's good. So at this point, we've accessed the L4-5 disc on the right side with a transforaminal approach. You can see the patient's spine is pretty deep. We are almost at the limit of the needle. We're going to make a 7mm incision, basically a 1/4 inch incision, and we're going to now access the next disc, which is 3-4. Let's do some num-num. Help Dr. Berndes and the patient a little bit. We're going to use a little Novocaine, Marcaine to numb up the pain-sensitive structures. Make the patient a little more comfortable. Now, patients that have what's called sleep apnea, meaning that they obstruct their airway when they're sleeping and they stop breathing, They're patients that are at a higher risk of anesthesia complications because of that. So we don't want to give those kind of patients too much sedation because they stop breathing. So it's important that we modulate the anesthetic just perfectly, which is really hard to do. And by doing that, getting it just right, you keep the patient comfortable but safe. And it requires the use of not just anesthesia through the vein or like we're using propofol here, but it also requires some local analgesic or anesthetic, which is the lidocaine and marcaine. Shot? Once again, I'm bumping the facet. I'm going around the facet. Shot? And I'm aiming for the herniation. And I could feel it right there. Yep. So let's get an AP, check our position. You're doing great. Lay still. All right. Yep, that's looking good. We're right where the disc is. Just at the back of the disc at L3-4. Now we can't show you on his MRI, unfortunately, but if you look at his MRI, you'll see he has really big herniations right here in the foramen. All right, so we're going to get rid of those herniations. Shot. And we're going to treat his annular tear. All right, you're doing great. Just lay still. I've already numbed him up with Novocaine. Let's do a little bit more. A little more Novocaine right here.
Right there?
No. I mean in here. Any questions from our audience?
No current questions.
That's great. That's enough. So just to reiterate, this patient has traveled from Canada to Florida for the Duke laser disc repair, the endoscopic surgery we're doing. And he didn't want open surgery. He's already had an open surgery called a laminectomy. And basically, he didn't want another one because they don't really work. Laminectomies are really bad at fixing back pain. Sean? Laminectomies are okay at fixing leg pinch nerves going down your legs. Sean? Any way we can make him a little more comfortable? Sean? 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 All right, so again, now that we've completed the patient's right side, I'm working on his left side. Let's get an AP, see where we are. All right, so I need to be a little, I'm too medial, posterior. I need to be a little bit more lateral anterior with my tip. I think I might start just a little bit higher. Shot? Shot? The good news is these needles don't really cause any injury as long as you're in the right area in the back of the spine. You can manipulate them, move them in and out, and they really don't harm anything. There's nothing back there you can harm, but you can reposition them, move them, adjust their direction. That's beautiful. So if you look at the left side of the screen, you see the single needle tip right at the back of the disc. Show us the pedicles of L4 and L5. There's the pedicle of L4. It's huge. pedicle of L5 is a circle there. And you can see the tip of the needle is almost right in the middle between the pedicle mid-pedicular line. That means we're very close to the back of the disc right there. That's where we want to be. Any questions from our audience?
No current questions.
All right, so at this point, let's show our audience why do people with herniated discs get back pain? Sean? What is the cause?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, we're trying to access, Sean, L3-4 at this point. Sean, and that is the top two needles, Sean. The hardest part of this surgery, by the way, I've said it before, is the access, which is what we're doing right now. That's called access, A-C-C-E-S-S. It means getting to where you need to go. And that's what we're doing at this moment. AP, we're just about done. Once you have access, proper access, you know you have a safe path from the skin and our operative fields into the tear and the herniation. Okay? Once you have that path navigated with the needle, then the rest of the surgery becomes quite easy. It's just getting to the right spot through the right path that's difficult. Yeah. So we're there. Our patient can be woken up now, and we're going to want to test his discs. Now, how long has he had back pain for? 10 years. 10 years. By the way, he is a doctor, and his wife is a doctor, and they've traveled here from Canada to have this surgery done. Looks good. So his pain is in his back, and he's had a laminectomy already, which created a lot of problems, a lot of scar tissue and damage to the soft tissues back here, which we cannot undo, by the way. That's why you want to avoid laminectomies. But I believe 95%, lay still, you're doing great. 95% of his pain is coming from these two discs that we're about to fix. And certainly these discs have these herniations that are pushed out on the sides, and they're pushing against the nerves that are going down his legs. Okay? And whenever a nerve gets pinched by a herniation, it's the most common reason why people get leg pain or sciatica. These nerves come down and they go right past the back of the disc as they head down your leg to your toes. So the herniations, I could see it on his MRI, they're literally crushing his nerves out in the foramen. The foramen is that hole in the back of the spine where we're going through to get into the herniation, okay? So we're actually passing through the foramen right into the herniation with the needle. And that's where the nerve is getting pinched. So we're just lateral to the traversing nerve and just underneath the exiting. So now that we have him awake, are you comfortable?
How are you doing, my friend? You okay? You okay? Yeah. Okay.
Yeah, you're doing great. We're going to put you to sleep in a minute, but I need you awake. So this is the L3-4 disc, and this is the L4-5 disc, and we're inside both. How long have you had back pain?
More than 30 years.
30 years?
10 years.
10 years. So 10 plus years of back pain.
Or more.
Or more. So more than 10 years.
Yeah.
That's what he said. Greater than 10 years. How long have you had leg symptoms?
About the same.
About the same. So more than 10 years of leg symptoms. The leg symptoms are pain down the leg, uncomfortable feelings, weakness, numbness. Everybody's different, but in general it comes from the nerve root being affected, okay? So,
Yeah.
are you comfortable?
Yes, I'm good.
Any pain right now?
No.
None.
No.
How bad is that on a scale of 1 to 10? How high? How high?
About 8.
8?
Yeah.
That was L4-5, 8 out of 10. Is that where you get your back pain typically, in that area?
Yeah.
Concordant. Very good. Well, we found one of the two bad discs.
Oh, good.
Feels better now, right?
Great.
You comfortable?
Yes, I do.
How bad is that on a scale of 1 to 10? How bad? 10? Is that where you get your back pain?
Between 8 and 10.
So that was a 10 over 10. Is that where you typically get your back pain?
Yes. Mainly let's take the
I understand, mostly leg pain. But that's where you get the back. All right, now we're going to put you to sleep, and when you wake up, we'll be done with your surgery, okay? You did fantastic. So far, so good. I would like for you to count out loud for me from 1 to 100.
Hold on 1 second. We're going to reposition him so he's more comfortable. I'm going to give you this right
Do you need any help, or are you good?
now. Put your head down. We're going to move like that.
Watch out for the table. All right, so our patient, for those of you watching, we did what's called an evocative discogram, where we actually test the discs to see if they're causing his back pain, and indeed they are. We just confirmed that. The L3-4 disc was a 10 out of 10, severe pain, and L4-5 was an 8 out of 10. So now we know his back pain is definitely coming from these two discs, 100%. Now I asked him, because he has a herniation at L5-S1 as well, down here, and I asked him on his exam yesterday when I saw him, I said, where is your back pain? And he pointed to this area here. And I said, what about down here? And he said, no, I don't have any pain down there. So by doing the physical exam, I could localize where his pain is coming from. And I know I've done so many back surgeries. I've opened up the back and I've seen the spine. I've operated on the discs, literally 3,000 or 4,000, 5,000 surgeries on discs. I know exactly where L5-S1 is. I know exactly where L4-5 is. I know exactly where L3-4 is. So when I did my exam on him, I asked him, do you have pain here at L5-S1? He said no. Can you count out loud?
Yeah.
We need to hear you counting.
1, 2, 3,
If you make it to 100, I don't have to pay the anesthesiologist today. Maybe he knows that. That's why he's going slow. All right, we're going to start with the L4-5 on the right. Shot, you can see the guide wire is in the L4-5 disc. I'm removing the spinal needle, leaving the guide wire, and now we're going to use this guide wire as a road map to get down into the herniation. I want you to pay attention, folks, to this dilator. You guys see the tip of it?
Yes, we do.
It's tapered. Tapered means it comes to a point. It goes fat here, narrower at the tip, and the reason for that is it spreads the tissues. So what are the tissues under the skin? You have fat, you have fascia, muscle, and that's it. 3 things: fat, fascia, muscle. All 3 of these can be spread apart and not damaged at all by passing the dilator through them. The only tissue that is damaged in this whole surgery is the skin, because the skin, it doesn't have fibers. It has cells, like a wall of cells. So it's the only thing we actually cut and hurt during surgery. Maybe a blood vessel like a vein. Okay? So, long story short, this surgery is minimally invasive, but also minimally damaging to the body. Unlike open back surgery, like laminectomy that he already had, which is horribly damaging. It just destroys your muscles, your soft tissues, your fascia, your fat. So he's a doctor and he knows that. He didn't want that. Now you see how we're going through the tear? That's exactly what we want. We want to pass through the tear that's already there. By doing that, we're not damaging his disc at all. You're fine. You see that? We went through his tear where the herniation is just to get into the disc. That's the beauty of this surgery, folks. There's no other surgery in the world that does this but endoscopic transforaminal surgery. Unfortunately, most surgeons don't do this surgery because they're so conditioned and trained to do fusions and artificial discs. But this is really the best. Yeah, I understand the hammering is bothersome to some people, but it's necessary. People ask me, why do you hammer? Because it's the safest way to implant this tube. Okay, perfect. You can see from the view. Jordan, show them on the x-ray and go back to the x-ray, Henry. You can see the tube is in the tear of the disc. And now we're going to remove the herniation from the tear because the tube isn't exactly where it needs to be. That's fine. All right, any questions?
Yes, we have a question from Sunil Patel on Facebook. And they asked, how many months will it take to be fully recovered after this surgery?
Well, Sunil Patel, thanks for asking. A recovery is when your body is recovered. And the surgery recovery literally takes 1 day to recover. However, there are healing that still occurs after 1 day. Okay, the skin usually takes a week to heal. And the disc itself that we're repairing, well, this is going to take a full year to completely heal. And it's not healing from the surgery, it's healing from the tear that was already there. We didn't make the tear with the surgery. The patient made the tear with their injury. All we're doing is we're debriding the tear to allow the body to heal the tear itself naturally. So this is a natural healing surgery. It's the only natural healing surgery for the spine in the world. And it also happens to be, Oscar, please, the best surgery because it's the least invasive, the safest, the most effective. All right, great question, Sunil Patel. There's a piece of herniation right there we're going to get rid of. Go back in with the laser. We are inside the tear and we're removing pieces of herniation from the tear. A lot of doctors don't talk about the annular tear because they don't understand it. They don't understand how important it is. It is the most important thing in a herniated disc. It's the #1 cause of back pain in the world. See the tear right there? Is he doing all right? Yep. All right. You can see the herniation right here. You can see the tear. Any other questions at this time?
No current questions.
Let's go ahead and roll the video on how does this Duke laser disc repair actually work.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. As you can see, we're busy repairing this disc. This is going to be your lumbar disc, L4-5. And we've got 3 more to do after this. This is the herniation, by the way, right here. Look at how it's turning a brownish color. That's part of the herniation, I should say. There are many parts of the herniation. There are some fresher parts, the blue stuff. You know, we saw some fluffy blue. That's a fresh herniation, meaning it's just a few months old. But when you get a herniation that's really old, this is what it looks like right here. So, you know, the truth is, and nobody talks about this because nobody does endoscopic surgery really in the United States. And the truth is that you have a population of herniations here. You have some old ones, you have some young ones, you have some middle-aged ones, and a herniation isn't a one-time event, it's a multiple-time event. You see that right there? That is the annular tear. With the blue stuff is the herniated disc, the herniated nucleus pulposus, normally found in the center of the disc, but squeezed out into the tear. This is what's causing the back pain. It causes back pain by creating inflammation. Now I gotta say, what's interesting to me, it's funny, and I certainly appreciate it. Don't take this the wrong way, but I've had several patients now that want me to sign my autograph on a Duke Spine hat or shirt, and it's just funny because I'm not used to doing that kind of stuff. And but I appreciate the sentiment, obviously. I remember one day I half-jokingly said to my staff, we ought to sell Duke Spine merchandise for patients that want it because they're asking for it. And so apparently my staff bought jackets and hats and all kinds of stuff. And I guess people are interested in that. So I have to say I've never really thought of, as a spine surgeon, being somebody that you'd want your autograph with, but I'm happy that they're so appreciative of what we do. All right. We're just about done with this right side L4-5 disc. And you can start to see at the top there that white fibers are the posterior longitudinal ligament at the back of the disc. And that's when you know you've gotten outside the annulus and you have the posterior longitudinal ligament. Well, I have some exciting news. Duke Spine Institute is embarking on a new study that we're starting today with Arias. My son is the lead investigator, the head investigator. And the study is going to look at the causes of back pain. And it's going to break down the causes, and it's going to identify the frequency of each cause. And we're going to go so specific that you could look at the L4-5 disc. You could look at the L5-S1 disc. How often is the L5-S1 disc the cause of chronic back pain? How often is L4-5? So we're going to be looking at each and every cause of back pain and what we have encountered at Duke Spine over the years as being the most common, and we're going to rate them and assign them a value based on their frequency. We're going to do the same thing for neck pain. Now, why is this important? Because there's no study that I know of that's ever been done that's looked on a large scale of the actual source of back pain and neck pain. And that's because most doctors believe that they call it non-specific back pain. And so many people have been diagnosed with fibromyalgia when they don't have fibromyalgia. They have a treatable cause of back pain. Okay? They don't have fibromyalgia. And Arius, if you're listening, we need to include fibromyalgia as a cause. And you're going to see it's virtually 0 diagnoses of fibromyalgia out of thousands and thousands of patients. So let's add fibromyalgia as a cause, because we're going to want to report how many cases of fibromyalgia we've seen. Fibromyalgia, for those of you who don't know, is an uncurable condition. It's pain coming from soft tissues, aka the doctor says, I have no clue where the pain's coming from. I'm not trained well enough to know, so I'm just going to call it fibromyalgia. And boy, you need to be on pain pills the rest of your life. It's a nonsense diagnosis, folks. I'm sorry. I know there's whole societies of fibromyalgia. They're going to get very angry with me. But we have not seen a single case of fibromyalgia at Duke Spine Institute in the last 16 years. And believe me, if they were out there, they'd come here, because that's all we treat is back and neck pain. And fibromyalgia patients have primarily back or neck pain. So where are they? The reality is it's a diagnosis of uncertainty, meaning the doctor is uncertain of the real cause. So they call it fibromyalgia. Now I realize this is going to create a lot of hate mail, but don't be so shallow. Understand what I'm saying is actually good news. If you have fibromyalgia or know somebody with fibromyalgia, it's really not fibromyalgia. It's probably facet joint pain or disc pain. You just haven't been diagnosed properly. So you have an opportunity now to fix that and stop living in pain the rest of your life. Come and get it fixed. I'm sure there'll be haters out there who are not happy with me, but I'm sorry, I have to tell you the truth. So Arius, we definitely want to add fibromyalgia to our diagnostic group. All right, we're just about done. You can see the fat there. Those are fat cells, a little bit of veins, and this is all past the disc. So we're done with the disc. You see those thick fibers right there? That's posterior longitudinal ligament. That's past the back of the disc. So I know that we've completed the annular debridement because I'm seeing PLL. And you can see the end plate right there. The pink thing is the bone on either side of the disc. If you think of the disc as a hamburger patty, like a meat patty, you've got the buns are the bones on each side. You're doing great. There's the last of the tear right there. And that's lateral. So this is great. We're pretty much done here. Okay, done with one disc. Herniation, pinching of the nerve is treated. And we are now done with the annular debridement. You're doing great. So let's take a look at the nerve root. Should be right up here. There it is in that fat. You see that down there? It's really hard to see, but it's underneath the fat right there. That's the nerve root. Oh, let me get this blue right here. Laser on. This is a little bit left of the herniation, just below the nerve root. I want to get that.
I'm going to keep him a little lighter than the normal.
I understand. As long as he's safe, that's all that matters. He won't remember any of the surgery anyway, right? No, I don't know that I can do any extra num-num right now. That's it.
Eyes on, please.
We're right around the nerve, so I don't want to give num-num here. All right, so one disc down, 3 more to go. You're doing great.
Doing really well, my friend. Slow, deep breath. In and out for me.
This patient is going to be a little bit on the wake side because Again, some patients won't tolerate deep sedation because of breathing issues, like sleep apnea. So as a compromise, we have to keep the patient more awake, but we get to do the surgery. Otherwise, they wouldn't get surgery. Or we'd have to do them under general anesthesia, which we really don't want to do. We need our patients participating with their surgeon. All right, one down. I'll take care of that. We're going to take the tube out. It's done its job. I'm always going to apply a little bit of pressure to the muscles so that they don't bleed. And I don't think they're going to bleed, but we do it anyway as a precaution. We've never had to do a blood transfusion on any of our patients. We never lose more than, say, 5 or 10 milliliters of blood, which is virtually nothing. The average human being has 4 liters of blood. We're losing 1 milliliter. 4 liters is 4,000 milliliters. You have to lose 20% of your blood volume, which is about 800 milliliters, before you start having symptoms of blood loss. And we lose 1 milliliter to 5 milliliters, so far from 800. All right, but there are spine surgeons that lose 800 milliliters or 1,000 milliliters of blood during their spine surgeries. Not us. Not at Duke Spine. Shot? All right, very good. So we've got our guide wire in position. We're going to remove the spinal needle. Then we're going to have a path for the dilator to travel. Safe path right into the disc. So who invented the transforaminal approach? Let's see if any of our audience remembers. It was invented by a surgeon in the United States. Sean? Yep. Lay still, you're doing great. His name was Dr. Parvis Kambin, K-A-M-B-I-N, Parvis Kambin, an orthopedic surgeon at the University of Allegheny in Pittsburgh, I believe, or Pittsburgh. And he developed a technique in the 90s and taught a few of his residents or fellows. And one of them went on to teach me. Actually, a couple of them went on to teach me. Pull it out. Shot. So I'm a second generation, I guess, or I don't know what you call it, second generation transforaminal lumbar endoscopic spine surgeon. But we've taken that basic technique that Dr. Kambin developed and we've made it better. Just let me know when. We put the normal amount of numbing medicine in the discogram, right? Yeah, he is more sensitive in the superficial layers. You're right. But we're not in the superficial layers right now. Let me know when. Sorry, Louise. Uh-oh, I'm in trouble with Louise now. I better not miss. I think that looks pretty good. Let's go one more for good measure. All right, that should be good. Shot? Yep, that looks good. How are your fingers, Louise? Oh my. All right. Any questions from our audience?
No current questions.
Oh, they know everything, huh? Folks, this is the time to ask questions. Anything related to the spine, we can do our best to answer for you. Once again, we're broadcasting live from Duke Spine Institute here in Florida. We're located near NASA in the Space Coast. And as a matter of fact, we're probably about 10 minutes from the launch site of the SpaceX satellite. Lay still. Here, you can see this is a painful disc for him. This is the one that was a 10 out of 10. So it's a bit uncomfortable. We're in the most painful disc right now operating. And that may be why he's a bit uncomfortable too. The other disc was not quite as painful. All right. Let's get started. Now, he told me in Canada the only surgery they offered him was fusion. And I believe it. Unfortunately, this fusion craze is spread everywhere. And you've got all these spine surgeons acting like zombies, mindless zombies, not really thinking about what's best for my patient, but just thinking about what's best for themselves. So that's my new thing, is zombie. All right? Because you could say they're like sheep, just doing what they're told, not really thinking about it. But sheep, everyone thinks of sheep as cute, fluffy, harmless creatures. But zombies are dangerous. And spine surgeons that do unnecessary, invasive surgeries are dangerous. By the way, what is that thing right there? Oh my gosh, did we discover something? Does this patient have a piece of metal in their disc? Absolutely. That's the needle from the other side. Remember, we're doing bilateral. So I want to avoid hitting it. If you hit it with the laser, you'll melt it. It looks like I already hit it once, maybe right there, but not too bad. You don't want to keep hitting it with a laser. You'll literally melt the steel, and that needle will fuse together, and then you won't be able to get the guide wire in later on. Okay? So you want to keep an eye on your double needles. This is the tear. You can see the inflammatory tissue, the pink stuff. How's he doing, doctor? This is all calcification right here, the golden. That means it's been there for a while. Oh, he's perfect for me. He's not been a problem. A little bit of movement I can tolerate. It's almost like we're dancing together. I'm joking. It's a slow dance. I'm not talking about locking and popping. I'm talking about just some nice, you know, a nice waltz. Huh? Not the tango or the merengue or the cucamarachas. This is just a waltz. I could tolerate a waltz. All right. If there's no questions, let's go ahead and run our video once again on how does a herniated disc actually cause back pain.
Traumatic injury to the disc can cause annular tears to form.
We're back.
All right. Sorry about that. We stopped the video because I want you to see this. You see that pink thing right there and all that pink tissue? That is inflammatory tissue. Not blood, but inflammatory tissue. And that's where the back pain comes from. There's little nerve fibers in there that are super sensitive to pain. And by zapping them right now with the laser, it gets rid of that source of pain as well as the transmitter of pain, the perpetrator of pain. Because remember, pain is what we call a cerebral or cognitive thing. There's no such thing as pain existing down here at this level. Those impulses are transmitted to your brain, specifically your cerebral cortex, the outer surface of the brain, and specifically to the parietal lobe, which is your somatosensory lobe of the brain. So pain is how you perceive those impulses in your brain. So it's really not pain down here, it's pain up there. But by getting rid of those fibers, getting rid of the source of inflammation, getting rid of the neurotransmitters and basically the cytokines that create the impulse of pain that transmits along those nerves to your brain. We're treating the back pain. All right, see the inflammatory tissue right there? Once again, look at how it's growing from the epidural area. There's little blood vessels from this vascular area getting onto the disc. And that's what this pink stuff is. Very important. This is literally, that was a good shot right there. Again, Henry, I need you to save that shot because it really shows the audience the inflammatory tissue we talk about being the source of the back pain and neck pain.
Copy
So
that.
can you save that section and maybe put it into our video testimonial, or save it for me in an archive so that I can ask you for it someday? We may want to put it in our publication.
Copy that.
Because most surgeons have never seen it before. They don't even know it exists. It's like capturing pictures of Bigfoot, you know, and then showing it to your friends. There's proof right there. Granulation tissue is what it's called. That's the source of the back pain. Inflammation in that tissue. All right, just about done here. This is going to be the most uncomfortable part of the disc for him because this is where the back pain comes from. And I can tell you this, people with a herniated disc that have back and leg pain, they generally will adapt their lifestyle and stop doing things that exacerbate or cause the back pain to aggravate. And the whole source of that pain aggravation is right there, that pink tissue, okay? So what they're doing is they're getting active and they're pushing out a little bit more jelly, and that aggravates the pink tissue. Yep, thank you. Thanks for letting me know. Have you already done it? There it is. All right, the burst of bubbles. Burst of bubbles means the irrigation has been changed. We went from one 5-liter bag to another. There's constant irrigation. People ask me, when you clean out this tear right here, this herniation, and it breaks up into little pieces, how do you get rid of those pieces? Well, the irrigation gets rid of them, the fluid moving through the tube. And that fluid is ice cold. And we use sterile saline, or lactated ringers, either one. Just about done. 30 seconds. Luis, I'll switch with you. Come over there. Any questions?
No current questions.
All right, let's rerun the video, educational video. Wait, you see that? That's his muscles contracting. You see how the walls kind of collapse? Watch. That's him tightening up his back muscle. There it is. You see that? How the sides come together? That's a muscle spasm, folks. See how the muscle spasm pushes on the disc? Oh yeah, baby. He's going to do great when he's all healed up. Just about done with the right side, and we're going to go over to the left side.
Good job.
I don't think anyone's ever shown a muscle spasm in a disc before, live, or even recorded. It's one of the nice things about him kind of moving his back a little bit is you can see the muscle spasms. All right, any questions?
No current questions.
Are we on the testimony or the video?
We can?
Yep,
Can
we're
be.
ready.
Alright.
I'm done with this one.
Alright.
We're gonna switch over to the other side, so it'd be a good time to show a educational video.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
We're just It's the fascia. It's the fascia, okay? Yeah, we're going to do it right now. Yeah, we'll do it. No, go. Good. So the heart didn't move, but the body moved. All right. Shot. Now we've moved over to the patient's left, and we're going to do the same thing. We've already repaired 2 discs on the right. Now we're going to go for the left. Where's the num-num? Going to put a little more num-num, a little more numbing medicine. And this should help with the discomfort. Shot. That's it right there? Okay. So, I'll give it a second to work. So far, everything's going well for this patient. He wasn't an easy case, but I think he's shot. I think he's more challenging from an anesthetic standpoint, more num-num, you know, just because he has a history of apnea, sleep apnea, which of course affects the anesthesia. Take shot. So far, so good. We're getting ready to start the L3-L5 on the left. I'm going to pull the guide wire back just a little bit. Shot. Good. Shot. Don't move, you're doing great. I think we're in. Good. Yep. All right. Now we're going to put our tube. This is the tubular retractor. Lay still. You're doing great. Almost done. Just a little bit further. That's it. Great. That should make it a little more comfortable for him. Go ahead. Let's get the fluoro out. So this is the L4-5 on the left. So far we've lost about 3 or 4 cc's of blood. Not bad. More than we normally do, but not much. 4 cc's is just 4 milliliters. It's like a nosebleed, not even a nosebleed. Nosebleeds are more than that. All right, you can see we're inside the disc. We need the pituitary. I'm going to try to take some of the herniations out with the pituitary. And once again, you can start to see some of that inflammatory tissue. I put it there. Another piece of herniation. We lost a ray in the bag. My wife was joking with me last night. She said, make sure you get lots of sleep and rest. You don't want to make a mistake and leave a sponge in the patient, right? We joke about it because with this kind of surgery, you really can't leave a sponge in the patient because you're not putting a sponge in the patient, right? But with all kinds of other surgery, there's always a chance the surgeon will accidentally leave an instrument or a sponge in the patient. I've never done that, fortunately. I'd never planned to do it either. But that's why you do a count at the end of surgery. You literally count all your sponges, make sure you have 10 of them after you're done, and you count your instruments. But sometimes we're all human. Sometimes people make mistakes, I guess. I personally don't see how that can happen, but it does happen. And it's never good, right? But you don't have that problem with the endoscopic surgery. We're back by now, right?
Yeah, we're back. We're back.
Okay, just finishing up. This is the L4-5 left side. Any questions so far from our audience?
No current questions.
All right. Well, folks, if you're interested, we offer our free app, the Duke Spine app. You're welcome to download the app onto your phone or computer. We've got great content. You can learn a lot. And we're in the process of redoing our entire website. So we're going to have what I think is a more user-friendly, better website soon. We were supposed to have it done and launched beginning of this year, but we're already behind schedule. It's taken longer than we thought. All right. There is the tear. It's a big tear. You see that, the blue? This is all herniation. It's stuck inside the tear. We have about 5 minutes on this disc, then we'll start the last one. Our next patient is here, ready to go. Yes?
The next one? I don't know, Stephanie, the next one is ready to go? Yeah, it's ready to go.
Next is a DPR.
Yes, sir. Yes, sir. Yes, well, two spots. Two spots, two spots.
One level, one facet, right? Two nerves. Or is it two facets?
No, five.
Just one.
Yeah.
One facet, two nerves. That was pretty cool, huh? Doing the sacral Duke plasma rhizotomy, making history today. Earlier, we performed an SI joint rhizotomy to treat sacroiliac joint pain. Everybody else is doing fusions of the SI joint. We are now going in and zapping the pain nerve with the Duke plasma rhizotomy. And I already saw the patient. He was doing fantastic after surgery. Is he gone?
Yes, sir, he is.
There's the tear. You all see the tear there?
Yes, we do.
So we call this a 4-level, for those of you who watch us regularly. 4-level means we're doing 4 spots, 4 discs, 4 areas, because each side in the lower back is considered its own level. So if you have an L4-5 and you're doing right and left, it's a 2-level. All right, any questions from the audience?
No current questions.
They know everything. Does Arias have any questions for me?
believe so.
About the project. Since I'm not doing anything else.
He walked up and then walked back.
Is that, what do they call that? Stage fright? Fear of the microphone? Do you have a change of heart, son?
So,
Ah,
hello.
hi.
My question or sort of comment is, we have to use I guess
Just a little bit louder.
ICD-10 codes give you the actual diagnosis of the back pain. So, it'll
They
be...
don't.
Uh,
They don't. You can't trust the ICD-10 codes that were listed because we didn't actually have somebody go through the charts and look at every single diagnosis and put every single ICD-10 code. And the reason is simple. The medical record system we use only allows you to put 4 ICD-10 codes in per visit. But most of these patients have 10 or 15 ICD-10 codes. So we're going to be missing the vast majority of them. So we cannot rely on ICD-10 codes for the project. We have to do a chart review. It's a great thought, though. All right. So Arias, as I've said before, is going to Princeton next year, and this year he's spending his time doing medical research and publishing, and it's an opportunity of a lifetime. I never had that same opportunity with my father. My dad was an OB-GYN, and he passed away before I had a chance to do any kind of research with him. But Arias is learning the basics of clinical research. There's 2 types of scientific research. There's clinical, and there's what we call bench research or laboratory research, where you do research on biochemistry, cellular biology, bacteriology, microbiology, immunology, etc. Basically lab research. And then there's clinical, where you're dealing with patients and patient outcomes. So he's learning clinical research, and someday when he goes off to Princeton, he'll probably work in a lab and he'll learn how to do basic biochemical, basic science research, basically. Just about done. For those of you watching, you could see the laser fiber. That's the glass tube at 12 o'clock. That is 1 millimeter wide, 1 millimeter. That gives you an idea of the scale of how big everything is here. And you can see how it works. I just touch the tissue and it vaporizes it. So it's an incredible device, very efficient, very precise. People think that it shoots the laser out across the disc, but it doesn't. Because we're in a liquid medium of water, the actual laser doesn't travel very far. Now, if we were in air, the laser would shoot across. But because we're in water, submerged in liquid, that cools the laser, keeps a fire from happening, but it also diminishes or immunizes the effect of the laser, the effective range of the laser, and which is perfect for our purpose, what we're trying to do. Because we're just trying to fix this area right at the tip of the laser, so we don't want it shooting around everywhere. Okay? All right. Now once again, this patient is from Canada. Our first patient this morning was from Canada. He had a 2-level cervical Duke laser disc repair, and he did great. His arm pain was gone in his right arm after surgery because we removed the herniations that were pushing on the nerves in his foramen. All right, look at that little bit of fat right there in the epidural space. It's got some blue dye in it. Blue and red make almost black. So a little bit of blood, little bit of blue Duke spine dye in the fat, and it turned it an interesting color. What? Oh yeah. You're talking about for this disc or the whole surgery? This disc, 1 minute, maybe, and then we'll get started on the last disc. This is the annular tear. I'm looking laterally. A lot of doctors don't know they're supposed to look laterally. This is medial towards the midline. The other direction is lateral. You need to go both ways because the herniation will be on both sides. A little medial and a little lateral. Just about done. I just want to get this last bit right here. So I'm going to pull on my tube. I'm going to pull my tube towards me. That will help angle the tip more medially and help me get this last bit of herniation here that needs to be gotten. All right, any questions from our audience?
No current questions.
All right. Well, I know his wife is here and she's a doctor and she was supposed to watch. Hopefully you're out there watching and enjoying. Your husband is doing fantastic. No problems. Everything is going very smooth. Surgery and anesthesia. Now, for those of you wondering, at 12 o'clock up there in that fat is what's called the traversing nerve root. That's going to be the nerve that travels down and comes out the next disc. Okay? So we're doing a decompression of that root as well as the nerve that's exiting at this disc. That's it. I think I'm done. I don't see anything more I can access or get. I'm very happy. I'm going to take this out. I'm going to show you, or try to show you, the nerve that is right above us. Laser off. So let's see. It should be right up there. All right. There's a little bit of right there I want to get with the laser. Let's bring the laser back for a second. It's just the smallest piece, but we're here and I want to get it. All right. That looks good. Okay, great.
Lights on, please.
Well, couldn't really see the nerve root because it's sitting in all that fat up there.
Thank you.
But fat's okay. We're not here to take fat out. Fat doesn't do anything bad. It actually gives the nerves energy.
And this one,
At this point, we're just putting a little antiseptic. And then we're going to take the tube out and do our last disc, which will be the L3-4 on the left side. How was that with the Novocaine? Good? Good. We'll just do the same thing. Yeah, the disc itself is numbed up. I understand. So we're going to take this tube out and just put a little bit of pressure on the muscle once again. So what we're passing through, folks, is skin, then subcutaneous tissue, then fascia, then paraspinal muscle, and then right into the foramen and disc herniation. And the muscle, fascia, and fat and the subcutaneous tissue, none of it's damaged with the dilator. It's spread apart and then it comes back together when we leave. So there's really no internal damage done. The damage that's already done at the disc, well, it was done before we got here. So we're not causing any new damage. We're just going through the area of old damage. This is the only surgery in the world that does it this way, and it's the best and safest way to do it. All right. I'll do that. Did you already close that or no?
No.
All right. Shot. All right, so I'm putting the guide wire in, shot. And there it is. Guide wire is in position. Now I'm going to remove the shot, remove this needle, and we're going to be left with the guide wire in place. I want to put a little bit of pressure. All right, guide wire looks good. I'm going to run the dilator down the guide wire. And we're going to put some more Novocaine as we do that, so it numbs up his back, so he remains comfortable. Shot. All right. Shot. Perfect. Shot. Very nice. Right there at the back of the disc, I can actually feel the herniation. It's good size herniation. Shot. All right. Shot. Perfect. Nice. Very nice. Take it. All right, so the dilator, huh?
Yeah.
Yeah,
Good.
dilator's in place. Beautiful. Take the guide wire out. You're just trapped, that's all. You'll be able to get it. No, don't bend it. Just straight out. Ooh. So we must be pinching it right at the tip. I'll just pull it back a little bit and we'll be fine. Should be good now. Try that. Sorry about that. I bent your guide wire pretty good. All right. Uh-huh. Advancing the tube, shot. That looks great. Go ahead if you can. Any questions from the audience?
No current questions.
Let's show the video on the Duke laser disc repair one more time, so they understand what we're doing and why we're doing it.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. I know we have a few people watching. If you have questions, feel free to ask. I don't mind taking questions. But we're performing spine surgery, and this is state-of-the-art spine surgery done endoscopically with a tiny 7mm incision on the back. And we're able to fix 2 discs on each side with 1 incision on each side. It's a Band-Aid incision, which means recovery is going to be very quick. Stand by. Let's go grab her. Recovery for this surgery is usually an hour. And honestly, after an hour, patients could probably feel like driving, but they can't. But you're up walking, you can eat, drink, you're not in the hospital, you're outpatient, so you're going home. And people are usually home within an hour of their surgery. Taking it easy, of course. We don't want anyone doing too much on the day of surgery, but by the next day you can go shopping, driving, you can do most anything you want to do except for heavy labor. So we want our patients resting up. This yellow thing is going to drive me crazy. All right. Once I want to get to the back of the herniation, right where it comes out through the annular tear. This is all part of the herniation. See how golden color it is? That's calcium. That's fine. We have about 5 minutes left. Thank you. No problem. 5 minutes, doctor. Did you hear me, Berndes? Yeah. Just about finished. Great. A lot of older herniation right here. Herniation right there. More pieces of herniation you can see coming out, floating around in the tube. Little gremlins. That's what they are. Little gremlins. First of all, they're gremlins because they're causing pain for the patient. Now they're causing pain for me. All right. Watch him, Luis, watch him. Grab her. Watch him. Yeah. Not really grabbing out any big pieces of herniation here. Just a lot of little pieces. Almost done. You're doing great. Lay still. Is he going to be amnestic? Huh? Yes? That would be good. Just another few minutes right here. I just need 2 more minutes. Okay, 30 seconds. You're doing great. Lay still. Just about done. I don't see anything more. Nerve roots are going to be up there again. Done.
Lights on, please. Thank you.
He did fantastic. You're all done. Irrigation.
You're all done, sir. Congratulations.
You did great. Just hang on. We're just finishing up. We're going to put a bandage on in a minute. You did great. Everything went very well. No problems. Watch the needle there.
Yes, sir.
All right, this needle is sticking up. I don't want it to get your hand or anything. Just be careful. All right, folks, we are done. If you have questions, feel free to type them up. Surgery went well. We didn't have any problems. Now let's see. I'm going to show you the incision. Can you see this here, Henry?
Yes, we do.
7 millimeters, Band-Aid size incision. And you can see one of the pieces of disc material right there. There's lots of them. One of the things the laser does is it allows the disc material to be blasted everywhere. So this one's around 8 millimeters. I got a little generous there, a little over exuberant. I went from 7 millimeters to 8 millimeters on my incision. Gonna have to work on that. All right, type your questions up, folks. I'll come and answer them for you, but we're done. Bilateral, L3-4 and L4-5. I got a Duke laser disc repair. All right, I'm here with one of my patients who traveled from Australia to Florida to the Duke Spine Institute for treatment. And you look happy today.
Yeah.
Yeah? Why are you so happy?
I'm happy because my back pain is gone.
Your back pain is gone.
And my leg pain is gone from
Awesome.
the disc here.
From the surgery yesterday.
Surgery yesterday, yeah.
And you had the Duke laser disc repair.
I had the Duke laser disc repair, yeah, that's right, yeah.
So why did you come all the way to Florida from Australia for the Duke laser disc repair?
I've been suffering from back pain and leg pain for nearly a year after an accident. So I did a lot of conservative treatment like physiotherapy, exercise physiology, but it hasn't cured my pain. The pain was chronic, and I've been suffering from a lot of issues, emotional frustrations and things, and sleepless nights. But a couple of neurosurgeons back in Australia has offered me a surgery. They both offered me a fusion, which I don't want to go for. So then I have looked into Dr. Duke. I found Dr. Duke, and he's doing an amazing job doing a laser technology and also doing very minimally invasive procedure. So I thought this is what I wanted, and it's a faster recovery. I could go back and work back within a couple of weeks. So that's why I traveled all the way from Australia to US.
Yeah, and we did your surgery just yesterday evening.
Yeah.
So it's around 12 hours now from the surgery, and your pain is gone. And you can see in the video here where we did the laser surgery, we got into your disc endoscopically, and we used the laser to clean the tear in the back of the disc at L5-S1 where their pain was coming from all the inflammation. And now that back pain is gone. And you didn't have to have fusion. You didn't have to go to the hospital. You didn't have to deal with narcotics, right? You said you took a a couple of anti-inflammatories and a muscle relaxer yesterday.
Yeah, but I didn't have much pain about with the surgery because it's laparoscopic and minimally invasive, I believe.
Yeah, that's correct. That's correct. So there's not a lot of trauma. There's no scar tissue. There's just a little incision. And of course, we don't remove any bone or ligaments from the spine. It's all done minimally invasive and naturally. So it's a natural healing of the disc. Now, you said just a minute ago you were suffering with a lot of pain and the effects of pain on your psychological well-being. And I know what you do. You're a nurse who helps patients that have behavioral issues, you know, like anxiety, depression, and maybe other things. But you can appreciate how devastating chronic pain can be on people and the loved ones around them.
That's true. Yeah, I completely agree. It not only disturbs you, also your family. That's what I understood. So psychologically, after a few months, I should say, you will have that frustration of chronic pain, and then your behavior start changing towards others as well. And
Yes.
it's not really, you know, like about you. It's also about your people living around you. That's very important. Yeah.
You came here for a purpose. You got your surgery that you had hoped to do. Now you're going to go back to Australia.
Yeah.
You got a long trip ahead of you coming up. And how do you feel about your experience here at Duke Spine overall?
Oh, it's really good. Staff is really welcoming, and it's spot on, and they receive you with a smile, and which is really great. And my father was telling, oh, it's amazing how, he never thought that in American health system, people like, the clinicians are like this. So he was treated differently probably before while he lived in US, but it was really amazing, and your staff is really cool. I
Thank
should
you.
say, yeah, they're welcoming, they're good.
Thank you very much.
And you are the best, I should
I
say.
appreciate it. It's an honor to take care of you, and it makes me feel so satisfied to see you happy and out of that pain. So congratulations.
Thank you, doctor.
You're welcome.
Yeah. If you're suffering from back pain, this is like a very good cutting-edge technology and very advanced surgery, which Dr. Duke has developed his own, and without minimal, no damage to the bone, no damage to other things, and easily approaching to the disc and removing it. He is very skillful in reaching there without, manipulating any of your muscles or anything. And you can see from me that I have recovered within few hours after the surgery. So I would say if you don't want a long-term complications from the surgery, this is the best surgery you can get done by Dr. Duke here.
Congratulations once
Thank you,
again.
doctor.
All right, Dr. Dumajian here, and we have just completed our Duke laser disc repair, both sides, L3-4, L4-5. We've had some suggestions from the audience during the surgery, which we're going to start incorporating in the future shows, but we have to prepare. That said, every surgery we do is a learning experience, and we're always trying to improve on what we do. So we're going to make some improvements as a result of this surgery as well. Not per se the surgery itself, but some of the recommendations from the audience. It just goes to show that no matter how long you've been operating and being a doctor, there's always opportunities to learn. There's somebody who will come and teach you something new. All right, this surgery went very well. We didn't have any complications. Our patient had a prior laminectomy done in Canada, I believe. He is a doctor, his wife is a doctor, they're very knowledgeable people. They did their research, they found the Duke Spine Institute, they found our Duke Laser Disc Repair, and they recognized that it was the very best that could be done. They traveled here to get it done. They would have traveled anywhere to get their surgery done, the best surgery possible. Now, his problem was herniated discs, bulging disc, ruptured disc, whatever you want to call it. There's about 10 different names for the same thing. Herniated, protruding, bulging, ruptured, extruded, slipped, You know, I don't make these names up, folks. They're just out there. I think they're ridiculous. It should all be called herniated disc because that's really what it is. We make it so complicated. The disc is not that complicated, for God's sakes. It literally has a wall called the annulus fibrosus, and it's got a nuclear or jelly center called the nucleus pulposus. 2 parts. And then, of course, around the outside of the disc, there's blood vessels and nerves on the outside. Now, some people consider the bone surfaces above and below the disc as part of the disc. So this surface right here would be part of the disc, but it's really not. But it is the limiting area of the disc above and below. So this patient had herniated discs, and he had back pain and leg weakness, numbness, symptoms in his legs as a result of the nerves being pinched. So we went in on both sides. If you look at the spine, he was laying down like this. You could look at it this way. The front of the spine was down, the back of the spine here, and I came in from the side. I bumped against the facets and I went into the herniation right there. Okay, that's what we did. You guys see that? But I did that at L2-3 and L3-4 on both sides, and we were able to clean the tear where the herniation came out, getting rid of the herniation still stuck in the tear from inflammation. The fact that the herniation is stuck in the annular tear is a clear indication of inflammation. It's stuck there from scar tissue created by inflammation. All right, surgery went well. Any questions? No questions. I don't know if the question thing is broken.
No.
But it'd be nice to know that it isn't. Anyway, done. We're going to be back again shortly. We have one Duke plasma rhizotomy next, which we will not be broadcasting. We'll be back in an hour for another Duke laser disc repair. And our final surgery of the day will be another Duke laser disc repair at L4-5. And the patient that's the final surgery, which we will be broadcasting, is a bit interesting and unique. He went to a place in Virginia, just north of us, called the Virginia Brain and Spine Institute, and they did a discogram on him where they stuck a needle in his L4-5 disc. He developed an infection as a result of that. He went to Johns Hopkins. They diagnosed the infection in his disc and spreading to his bone above and below the disc. We call bone infection osteomyelitis, disc infection discitis. So he's been treated now for 8 weeks almost with antibiotics. And he heard about us, contacted me, asked me if I could help. Absolutely, we could help. By going in with the endoscope into the infected disc, I can clean it out with antibiotics, and I could put antibiotic powder in there that will stay in there fighting the infection for the next several months, which will really help him recover quicker. So that will be our last case. It's going to be an incision and drainage of an infected disc for discitis at L4-5 with the implantation of antibiotic powder, vancomycin powder, into the disc, and an intraoperative culture where we're sending off the disc material for gram stain culture. What we're culturing is bacteria to see what bacteria grows. We already know from before that he had Staphylococcus epidermidis, which is a coagulase negative staphylococcus or gram-positive coccus. It normally lives on the skin. Somehow, through a dirty procedure that was done at that other place, they infected his spine. Folks, this is what I talk about all day long, quality of care. We don't have that at Duke Spine because we do a clean job. You don't want your spine infected, don't go to a place that will infect your spine. All right, hopefully you enjoyed the broadcast, and we'll be back again in an hour.